Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today is going to be the continuation of the Pharmacology lecture series with Cephalosporins and the remainder of the cell wall antibiotics. So without much ado, here we go. Alright guys, let's get on with the Cephalosporins. As we know, cephalosporin is like a sister to penicillins. So the mechanism of action will be similar to that of penicillin. Well, what I mean by similar is inhibiting transpeptidase enzyme. This is an enzyme, transpeptidase, that a bacteria requires to make and strengthen its cell wall. And cephalosporins, just like penicillin, they inhibit that, which means their cell wall becomes weak, it breaks, and all the intracellular components leak out, and extracellular fluids, they go into the cell and drown the cell alive. They have generations that range from first generation to fourth generation, and that's what determines the gram-positive spectrum moving towards gram-negative spectrum when it comes to fourth generation. You can find the different names of the drugs in the Antibiotic Classifications video that we had made. The link is also posted here. We also need to know that cephalosporins generation 4 is also the group that does not have any oral medications. Now, important drug interactions. I really need to point out here that cefotetin is a drug that inhibits vitamin K carboxylase. Specifically speaking, cefotetin methyltriotetraxole. That combination of drug will inhibit vitamin K carboxylase. Now, why is that so significant? Well, it leads to warfarin toxicity and increased INR. Wow, that's a lot of information. What does that mean? Well, first of all, we need to understand what vitamin K does in our bodies. See, vitamin K is significantly important in balancing anticoagulant effects. What does that mean? Well, anticoagulation means blood thinning drugs, drugs that allow us to bleed longer and longer. See, remember in our studies we used to learn about the extrinsic pathways, intrinsic pathways of coagulation. Well, if you keep making them act further and further, you have what is called as anticoagulation actions, which is increase in bleeding tendencies. But vitamin K is important in balancing those actions. But cefotetin will inhibit the vitamin K carboxylase. Therefore, there is increased tendency of warfarin-like drugs, which are anticoagulant drugs. There's increased toxicity of them, which means there's increased chances of bleeding. That's why vitamin K inhibition is actually a bad thing, also known as drug interactions. Now, how does cephalosporins affect vitamin K actually? How does it really inhibit it? The background of vitamin K is that it is produced by our stomach gut flora of bacteria. Our bacteria in the stomach produce vitamin K, which then balances the activity of the warfarin and prevents its toxicity of anticoagulation. Cefotetin blocks and kills those bacteria. Remember, cephalosporins are bactericidals. So that's an important concept to understand. Now let's move on to carbapenams. That group of drugs also falls under cell wall acting antibiotics. How are they different? Well, they're beta-lactamase resistant. Remember, beta-lactamase from our previous video was an enzyme created by the bacteria to make these drugs inactive. And carbapenams are resistant to that enzyme created by the bacteria, so very strong drug. They act like beta-lactam penicillin binding proteins, so on the cell wall, breaks the cell wall of the bacteria and lets the cell die. What's the actual action? It's based on its wide spectrum, which means it covers all gram-positive bacteria and some gram-negatives, and now we're introducing anaerobic population of the bacteria. So carbapenams are the first cell wall acting drugs acting on anaerobic bacteria. What are the subgroups? We have imipenem plus Cilastatin. We have meropenem and ertapenem. So imipenem and cilastatin is a combination that makes beta-lactamase resistance. Otherwise, meropenem and ertapenem are inherently beta-lactamase resistant. Imipenem and cilastatin are drug of choice for Enterobacter and P. aeruginosa. And remember, cilastatin is a beta-lactamase inhibitor. It's an anti-beta-lactamase compound. It's not really a drug that acts on the bacteria. It just prevents the inactivation of this drug against beta-lactamase enzyme. Meropenem, it is one of the most stable carbapenams. It does not need any help like cilastatin. It's good on its own. And ertapenem is used specifically for respiratory infections. Next group of cell wall drugs, we have monobactams. Monobactams, mono means they're narrow spectrum, and the drug involved is called aztreonam. They're narrow spectrum, which means only gram-negative enterobacteria are killed by monobactams. Remember, killed, it's a bactericidal. It is best for gram-negative anaerobic. Now that is a drug we don't get to see a lot. No cross-sensitivity with penicillin. That statement means that if a person is allergic to penicillin with an anaphylactic reaction to penicillin, then it does not matter if you take monobactam or avoid monobactam. They're not really cross-linked. So it's a safe drug even when you're allergic to penicillin. It acts in synergism with aminoglycosides. Aminoglycosides is going to be our next lecture. It acts in synergism, which means if you take aminoglycoside and then you take monobactam, they become 1 + 1 = 3 in action, which means they exaggerate the action. It's not going to be additive action like 1 + 1 = 2. It's going to be 1 + 1 = 3 in action. But then there's adverse effects. There's going to be skin rashes and occasional abnormalities in function. Beta-lactam drug resistant. Now, along with it being one of the best drugs for gram-negative anaerobes, it is also beta-lactamase resistant. So that's a good quality. Next, we're moving on to vancomycin. Now, this is actually a showstopper drug for penicillins. You'll get to know why. The mechanism is slightly different than the other penicillins. It's not really a beta-lactam inhibitor. It is inhibition of synthesis of phospholipids. What is phospholipids? Well, think of it this way. The bacterial cell wall needs transpeptidase, right? It needs transpeptidase to make the wall stronger, but it needs phospholipid to even begin wall formation, and vancomycin kills the bacteria by touching the phospholipids and inhibiting its formation. It doesn't even let the bacteria form the bacterial cell wall. Forget making it strong or weak. And that's why it is not associated with the beta-lactamase enzyme like the other penicillins. So see how strong vancomycin is? It binds to pentapeptides known as diala. This pentapeptide is what inhibits the peptidoglycan polymerization reaction. That reaction leads to what is called as transglycosylation, and vancomycin prevents transglycosylation. All of these big words here, all it means is the formation of the bacterial cell wall is inhibited. Now that's a strong drug. Given IV, there is no oral formulations for vancomycin, and it is excreted from the kidneys. Also, it's the treatment of choice for MRSA. Remember from our previous video, which you can watch with our link posted above, MRSA is methicillin-resistant Staphylococcus aureus. So now a Staphylococcus aureus that is resistant against the methicillins is treated by vancomycin. It's going to be a life-threatening Staphylococcus or Streptococcus infections, and they're treated by vancomycin. Hey, you know what? Vancomycin may be a strong drug. It may be a drug of choice for even Clostridium difficile from overdose of clindamycin. It may even treat all of that, but remember, stronger the drug, stronger the side effects. There is something called as red man's syndrome. See, when you take vancomycin, immediately you have an increase in histamine release. And histamine being one of those cytokines or one of those mediators in our body that increases vasodilation. Vasodilation and rash appears, and that's why we have red man's syndrome. Remember, vasodilation causes more blood flow into the periphery, leading to a rash on the skin. Red man's syndrome. Important point. It also leads to ototoxicity, in other words, ear infections, ear toxicities, and renal dysfunction. Remember, it was excreted through kidney. A strong drug like that, excreting through kidney, can actually lead to renal dysfunction in severe cases. So, ladies and gentlemen, that was the end of antibiotic cell wall. Thank you for watching, you guys. I hope you guys learned something new and these notes are helping you. If there's any suggestions you may have, please leave them in the comments below and we'll work on them. Also, our next lecture is going to be on the antibiotics of the metabolic pathways. So please stay tuned, like, share, and subscribe, and make sure you hit the bell icon so you're the first to hear from us. Have a good day.